Hi, good afternoon. Welcome everybody to this um, uh, seminar on building the alliance in dedifferentiated liposarcoma, integrating personalized multidisciplinary care with innovative MDM2 antagonists in advanced disease. I'm Andrew Wagner from the Dana-Farber Cancer Institute. I'm joined by Dr. Nita Somaiah from University of Texas MD Anderson Cancer Center. Welcome, Nita. Thanks to PeerView and to SARC for providing the session, and to Boehringer Ingelheim for providing the educational grant for the symposium. Just a reminder, look out for additional polling that will pop up on your screen during the presentation. And please feel free to submit your questions. We'll try to answer them during the Q&A session at the end of the presentation. You can also view the slides and practice aids now and download them after the event. There's an email there that you can send a question to, or an email for more information, or also on X at PeerView. So our goals for today are to help enhance your understanding of the pathophysiology of dedifferentiated liposarcoma, molecular profiling techniques, and the latest clinical evidence supporting the use of MDM2 antagonists for advanced stage disease, to equip you with skills to construct personalized treatment plans based on these recent clinical trial updates, molecular findings, and patient-specific characteristics, and guidance on the nuances of care delivery with MDM2 antagonists, including patient counseling, adverse event management, and team-based care coordination. So with that said, we'll get started. Again, I'm Andy Wagner from Dana-Farber Cancer Institute in Boston. I think most of you know this, but for those of you who are not sarcoma aficionados, just a brief overview is there are about 15,000 new cases of sarcoma in the United States each year. Altogether, they comprise about 1% of cancers in adults, but there's between 50 and 100 different subtypes, depending on how you count them. About half of patients may present with or eventually develop metastatic disease. And the sarcomas are similar in that they arise from mesenchymal cells that differentiate along lineages of differentiation that can resemble fat, muscle, nerve, blood, lymphatic vessels, bone, cartilage, or other supportive structures in the body. And they can originate really anywhere in the body. We're going to focus today on dedifferentiated liposarcoma, and there are persistent unmet medical needs for this disease. There's a high risk of disease recurrence and mortality despite upfront treatment with conventional regimens. There often can be delayed identification and diagnosis due to barriers in accurately identifying and diagnosing the disease. And there can be limited knowledge among providers on emerging targeted approaches. And as mentioned, we're very pleased that SARC is supporting this and the Sarcoma Alliance through research and collaboration. And just of note, here's some upcoming events and resources for patients and care partners, as well as for providers. There's a Sarcoma Multidisciplinary Tumor Board, which is a monthly forum led by Drs. Gina D'Amato and Scott Acuno. It meets on the second Friday of each month at 12 Central Time. There's more information or how to submit a case is listed there at that website. And the Sarcoma Centers Registry is a relaunch of a database of sarcoma institutions, centers and practices worldwide, which will be updated with this world map by the end of this year. For more information, you can go to the SARC website listed there, or to apply to be included in it, you can also go to that website also listed. Okay, so partnership at the cornerstone of patient-centric care and team-based strategies to integrate emerging MDM2 antagonists in practice and future directions of care. I'm going to turn over to Dr. Somaiah now.
Hi, good afternoon, everyone, and thank you so much, Dr. Wagner, for that introduction and getting us started. So I'm going to be discussing diagnostic principles of DDIF liposarcoma and the importance of molecular profiling and where that comes in. And again, I'm from University of Texas MD Anderson in Houston. Just a little overview. So we do get presented, sometimes patients will have these lumps in their arms or extremities or their trunk, which could be just lipomas, which are palpable sometimes, sometimes not internal, but they're benign proliferation, and they're not a malignancy, and they are not a precursor for malignancy. So we usually don't do anything about it unless If the patient is bothered by it due to a functional limitation or appearance, then they get surgery. Liposarcomas, on the other hand, are a malignant proliferation of cells of mesenchymal origin that differentiate along an adipocytic pathway. So this accounts for approximately 20% of all sarcomas. So they are quite a common soft tissue sarcoma that we encounter, roughly 3,000 new cases per year and 700 deaths per year. Of this, we'll discuss the other subtypes that we're not really focused on this time, but myxoid liposarcoma accounts for around 30% of liposarcomas. A majority of those will have a translocation that forms this new fusion protein fused CHOP, which is a translocation between 12-16 chromosome. Less commonly, EWS CHOP translocations are seen. PIK3, so in addition to the translocations, in around 20% of cases, we might see PIK3CA mutations. They've also reported in the same pathway AKT and TERT mutations as well. This subtype is quite sensitive to chemotherapy, especially doxorubicin-based therapy and trabectedin. Response rates by RECIST are up to 50%, though we do see higher response rates if you use, the so-called Choi criteria, where you're looking at decrease in density. Myxoid liposarcomas have a predilection for extremities, but they may metastasize to other areas. They like fat-bearing areas, so they do go to the spine, like, spinal mets. You also get abdominal mets. So it's important that we, when we do imaging for this, or staging studies, we not only, sometimes for extremity tumors, we might only include the lung. We must do imaging of the entire chest, abdomen, pelvis. For pleomorphic liposarcomas that are relatively less frequent, these have abnormal or bizarre appearing cells, so pleomorphic-like. TP53 mutations are the most common, along with other genomic noise like alterations, and they tend to be less sensitive to cytotoxic chemotherapy compared to myxoid liposarcoma and even, D-diff liposarcoma. So we're still unmet need there as well. Now moving on to our main focus, which is the well-differentiated, dedifferentiated spectrum of liposarcomas. So well-differentiated liposarcomas for initial presentation are more common than the dedifferentiated. They are slowly growing soft masses, often very large at diagnosis. They're adipocytes with some pleomorphic nuclei and prominent lipoblasts, and we'll see a picture in the next slide. They have really no to very minimal metastatic potential, because I have seen these rare cases of well-diff liposarcoma with metastases, but local recurrence is quite common. Even within well-differentiated liposarcomas, there is a spectrum where we see the purely fatty appearance on imaging that we see, and along with a lot of adipogenic cells under the microscope. But they could also be sclerotic, and there's also this hypercellular, more cellular variant of well-differentiated liposarcoma, so it doesn't meet the criteria for dedifferentiation. They're called well-differentiated liposarcomas when they're in the abdomen or retroperitoneum, and ALT is another common term, atypical lipomatous tumor, for when they're found in the extremity. They may be curable by surgical excision, depending on the location and the size. As I said, the local recurrence is common, but they're poorly responsive to chemotherapy. We don't usually use that. So that's a picture that depicts what that looks like. Now, D-diff liposarcomas, they're rapidly growing. They can be, even dedifferentiated liposarcomas is a spectrum, so not all of them behave the same, but most of them have a poorer prognosis. They tend to be more rapidly growing than their well-differentiated counterparts, more hard masses, they're more symptomatic. And the pleomorphic part of the spindle cells, they could they could resemble sometimes leiomyosarcoma, so they can have smooth muscle differentiation. They could also have osteogenic, so osteosarcoma differentiation. So you could see a spectrum within this dedifferentiated liposarcoma as well. Local recurrences are very common, almost up to 80%, and there is risk of distant metastases, though it tends to be low, around 20 to 25%. Limited responses to chemotherapy with doxorubicin-based regimens, gemcitabine, docetaxel, or trabectedin. So few patients might benefit. They're usually found in the retroperitoneum or extremity, and those are the most common sites, but it can be found anywhere in the body, head and neck, trunk, chest. That's a picture that represents that. So before we move on, please take a moment to answer a follow-up poll on the clinical characteristics of dedifferentiated liposarcoma. Thank you. Moving on to the molecular features. So despite their striking different appearance and behavior, well-diff liposarcoma and D-diff liposarcoma share the same genetic alterations. So they have these giant ring chromosomes of the segment of chromosome 12q from 13 to 15, and they form these rings. And these include genes like MDM2 and CDK4, among others. So they tend to be amplified, as you can see with this MDM2 fish and on this IHC here. Again, what is important to note is you have to work with the pathologist because this MDM2 is not unique to liposarcoma. So just having MDM2 amplification doesn't make the diagnosis. But if it resembles a liposarcoma, or if there is a dedifferentiated liposarcoma and that's purely the component without any fatty component, and there is a diagnostic dilemma, sometimes the MDM2 fish can definitely help make that diagnosis. So it is an adjunct to your pathology. It's also important to note that these two tumors, we call them a spectrum, but they quite often coexist, as you can see in this image provided by Dr. Wagner here. You see the well-diff areas with the green arrow and the D-diff areas with the red arrow. And it's a very common presentation. So imaging characteristics are also very important in your process of diagnosis for this tumor type. We often in tumor boards will work with the, when the pathologists are there and when they look at the imaging, it also helps them decide what to do. The other important thing is biopsy location matters. So there was data, this is again from our institution, that the accuracy of pre-op biopsy for different sarcoma, like liposarcomas. And for D-diff liposarcoma, it was 37% accurate, when you compare it to the final path on surgery. Was much more accurate for well-diff. And why is that? Because these tumors are very heterogeneous, and you can see within a particular tumor, there could be pockets. So if you do a contrast-enhanced CT, those areas are going to be more contrast-enhancing compared to the others. And they do also correspond with a higher activity on PET. So we reported if the SUV is greater than 4, the likelihood of it being D-diff liposarcoma is much higher. So this could aid us in saying that when we're doing a biopsy, target the highly vascular areas, because finding a D-diff liposarcoma is important because that has prognostic implication and also will guide your treatment decisions. And I think from that, we move on to a case. So this is a fictitious name, but a real case. 47-year-old male with unexplained weight loss and an abdominal distension and pain. And this led to imaging that revealed a 15-centimeter lesion in the right retroperitoneum. So I will pose this question to my partner here on the show. How can the care team accurately identify D-diff liposarcoma from well-differentiated disease if we have a case that presents with a huge mass?
Yeah, thanks, Nita. So the imaging is certainly a great first step. In this case, we see this retroperitoneal mass. There could be a bunch of different potential diagnoses. Those of us in the sarcoma clinics will see this and say, of course, it's a sarcoma, and retroperitoneal sarcomas are common for us, but there are still a multitude of histologic diagnoses that these can entail. If we see a large component of surrounding fat, we'd be more suspicious of this being a dedifferential liposarcoma. But in this situation, I think we just see this solid mass in the right side. So clearly a biopsy is important. It's important in either case, but a biopsy here of that solid area would be hopefully provide diagnostic information. But then it's in the absence of a well-differentiated component, then we do rely on our pathologists to do often additional testing to make a diagnosis of dedifferentiated liposarcoma. So if there's the coexistence of a well-differentiated component, it's usually pretty easy for them. And without that, they're turning to other techniques. And so those can include immunohistochemistry for expression of MDM2, FISH for amplification of MDM2, or in some cases, next generation sequencing, as well as their other panels of immunohistochemical stains they might use to assess for other diagnoses. I don't know, there are other things that you would add to that?
Fantastic. You said it very well. And exactly, the key is using those molecular markers to help you make a diagnosis when it is not completely evident, either on imaging and what the pathologist says. And I know centers do it differently, but of course, most of the pathologists will run FISH or IHC because they can use that as a diagnostic companion for confirming a diagnosis. at least in our center, if that wasn't done or was not useful, and if they come to us with an outside diagnosis, we might run the next-gen sequencing at that point because it's ordered by the oncologist. Yeah.
Right. So I guess a question there, should other biomarker testing be performed? So we talked about FISH, other immunohistochemical stains, maybe next generation sequencing. Do you do other things? Do you do PD-L1 staining for these tumors?
Well, as of now, we don't. I mean, if again, it also depends on what the initial primary presentation treatment is going to be like. So if we have a diagnosis and we are planning on surgical resection of the obviously it's they have to see them up front if it's a primary location without metastases. If they think it's not surgically resectable up front and we're thinking of trying other systemic therapies as a neoadjuvant approach to make them resectable, which we occasionally do, especially these tumors in the retroperitoneum, if you're going to lose a kidney with it, and we think it's very aggressive up front, we sometimes might treat them up front. But I have not found it very useful to do full next-gen sequencing upfront for treatment decision making so far. It might change in the future, but we still run it with just data gathering. What is your experience there? Is that?
Yeah, I agree. We don't routinely run it for liposarcomas, but for our dedifferential liposarcomas, but maybe in the future it'll be a more helpful tool to help find therapies that might be relevant. So, and as far as this assessing, for example, this particular patient in this imaging, how do you decide if it's resectable versus locally advanced versus unresectable?
I consult my very expert surgeon. But
Good answer. That's my answer too. Yeah.
So, some of them are easy because, it also depends on the process where the patients come in. So sometimes they might land in your clinic, but it's still important if it's a primary tumor to consult with an expert surgeon to see if it's upfront resectable, if it's not, because that still is the primary treatment. And if it is borderline resectable and has very high grade features, you could always, there is we at least prefer neoadjuvant chemo because in this particular subtype where the chemotherapy response is limited, you want to only give it when you can actually assess response with the goal for surgical resection, because the goal is not, because we don't know if it really prevents a future recurrence right now, but we do know that it can aid in patients who respond, aid with the surgical outcome. So.
Yeah, no, certainly, referral to a surgeon is critical, surgeon with experience of this disease. And I'm always amazed that it could be something that a simple medical oncologist like myself would see and say, wow, that's extensive disease. There's no way this could be operable. And the surgeon will say, no problem. And correspondingly, it could be in a really bad location up against critical vessels, for example, and the surgeon might point out the morbidity associated with surgery and instead view this as locally advanced or unresectable disease and turn to other modalities like radiation or systemic therapy to try to control it.
Couldn't agree more.
Right.
Consensus. Okay.
Okay. All right. So I'm going to discuss a little bit about the clinical management, just as we started discussing now, and some of the more recent evidence around treatment options. So again, as we were just discussing, for resectable disease, surgical removal of the primary disease is preferred whenever possible. It's important, though, that not just the dedifferentiated component be removed, but an attempt also to remove well-differentiated components. In the slide here, the red circle is showing an area that's denser and presumably the dedifferentiated component, but the blue rectangle is highlighting this stranded, fatty-appearing material surrounding the kidney. And that's a pretty typical presentation for a well-differentiated component that can be in the perirenal fat and tissues. So it's not unusual for us to see patients in clinic who may already have had resection of disease, but just of that dedifferentiated component. In reality, that whole blue area likely needs to be removed, often involving the kidney, sometimes other structures like the psoas or the spleen, or depending on or part of the colon, depending on where the tumor is located. The role for preoperative or postoperative radiation therapy is often standard if this arises in the extremity, like it would be for other high-grade sarcomas. The use of radiation for retroperitoneal liposarcoma is less clear. This was the focus of the STRASS study, which looked at neoadjuvant radiation for retroperitoneal liposarcoma or leiomyosarcoma. And certainly for the dedifferentiated liposarcoma patients, there did not seem to be any advantage of doing neoadjuvant radiation therapy. There might be a suggestion of benefit for a pure well-differentiated disease, but that's a different discussion. There's also no defined role as a standard for systemic therapy or other chemotherapy for surgically resectable disease if it's localized. There are situations, as Nita was just describing, where neoadjuvant therapy might help facilitate surgery. Or if you were planning on adjuvant chemotherapy, but concerned about medicines like ifosfamide in a patient who's had a nephrectomy, then neoadjuvant therapy might make sense. But the role of neoadjuvant chemotherapy is currently being studied in STRAUSS-2, again, looking at retroperitoneal liposarcoma and retroperitoneal leiomyosarcoma. So hopefully in the next few years, we'll have an understanding of the role for systemic therapy before surgery for resectable disease. If the disease is unresectable or if it's metastatic, then we do turn to systemic agents. The standard first-line therapy remains anthracycline-based chemotherapy. There are different options here. It could be single-agent doxorubicin, doxorubicin in combination with ifosfamide, which usually provides a higher response rate, but associated with more side effects. In some cases, if someone has relatively indolent asymptomatic disease, then liposomal doxorubicin can also help control it. Response rates for these agents range in the 10 to 20% range historically. So not great therapies for this disease, but it can provide some disease control. Gemcitabine with docetaxel is also commonly used in second line for sarcomas in general, and even for liposarcoma in particular, and there's some retrospective data to support its use. Pazopanib is approved for other sarcomas, but it does not have an indication for adipocytic neoplasms. It was felt not to be supported in the phase 2 study, so it was not included in the phase 3 study. And there are some newer cytotoxic agents available, trabectedin and eribulin in particular, which are FDA approved for liposarcoma. I'll show you those data in a second, based on progression-free survival for trabectedin, or both progression-free survival and overall survival for eribulin. Each of those studies were comparing those agents with dacarbazine. So these are the PFS and OS curves for the trabectedin versus dacarbazine study showing an improvement in progression-free survival. And this is looking at combined liposarcoma and leiomyosarcoma, with a median progression-free survival of 4.2 months for trabectedin and 1.5 months for dacarbazine, but no difference in overall survival. But this did lead to approval by the FDA for treatment of these diseases after prior doxorubicin-based chemotherapy. And the data of eribulin compared to dacarbazine, this is showing just the liposarcoma cohort, showing an improvement in median progression-free survival from 1.7 months for dacarbazine to 2.9 months for eribulin, but also in overall survival from 8.4 months for dacarbazine to 15.6 months for eribulin. And this led to approval for eribulin for treatment of liposarcomas after prior doxorubicin-based chemotherapy. So in addition to standard chemotherapy, there have been a variety of approaches, variety of studies that have involved immunotherapy, CDK4/6 inhibitors, and MDM2 inhibitors that we'll turn to now. So of note, SARC conducted SARC-28, which was a study of pembrolizumab, an anti-PD-1 immune checkpoint inhibitor, in a variety of different soft tissue sarcomas. In SARC-28, there initially were 10 patients enrolled with dedifferentiated liposarcoma, and 2 of those 10 patients had partial responses, and that's shown in the light green bars in the waterfall plot on the left. This cohort was expanded, and with the expansion of the cohort, the response rate dropped to 10%. So although the response rate is low, there clearly is a subset of patients with liposarcoma who seem to have benefited from immune checkpoint inhibition. And you can see the change in target lesions there. On the right, again, the liposarcoma is shown in the green, with quite a bit of stable disease, even if patients are not achieving partial responses. Other histology-specific targeted therapies, again targeting the key driver oncogenes, CDK4 and MDM2. Now, CDK4, as you probably know, turns off the RB tumor suppressor gene, and MDM2 inactivates p53. So by using CDK4 inhibitors or MDM2 inhibitors, you can reactivate the RB pathway or reactivate the p53 pathway, and hopefully either obtain cell cycle arrest and slow the proliferation of the tumors or induce apoptosis and trigger the death of the cells. So there's a very strong preclinical activity reported by multiple groups of both CDK4 inhibitors and MDM2 inhibitors in models of liposarcoma. There are 3 different approved CDK4 inhibitors approved for treatment of breast cancer. But there's preclinical data, as I mentioned, showing the effects on liposarcoma cells, shown on the top there. The 3 different available CDK4 inhibitors are shown at the bottom: palbociclib, ribociclib, and abemaciclib. Again, approved for treatment of breast cancer. But these have been studied, or 2 of these at least have been studied in liposarcoma, including palbociclib and abemaciclib. There have been a few studies of palbociclib, and on the left, you can see the waterfall plot from one of those showing one patient who had a response out of 60 patients with a median progression-free survival in that study of 18 weeks. In the abemaciclib phase 2 study, there were 2 patients out of 30 who had responses and a median progression-free survival of 30 weeks. And these data are encouraging and led to a SARC study, SARC 041, which is a randomized study comparing abemaciclib to placebo, recently completed accrual, and we very much are excited to see the results of that study hopefully in the coming months to understand whether this is substantially better than placebo for management of this disease. So here's another example of a real case. So this is a man who at age 49 had a 30-pound weight loss that led to imaging that showed a large left retroperitoneal mass. He underwent resection of combined well-differentiated, dedifferentiated liposarcoma, and remained well for 7 years until he had asymptomatic recurrence that was noted on imaging. So that's a common pattern with these retroperitoneal liposarcomas, is that it can take a long time for them to recur, but they, especially in the retroperitoneum, are likely to recur because of their preoperative contact with surrounding tissues and the inability really to get a negative margin. So with this recurrence in his nephrectomy bed, he underwent a second surgery, and this time it was a 10-centimeter mass, which also involved resection of some surrounding organs. We do prefer, when possible, and in consultation with surgery, of course, to manage recurrences with repeated surgeries when it's feasible and when there's been an adequate disease-free period in between the surgeries, reflecting again the biology of the disease. So he stayed well for 3 more years when he developed another recurrence in the left retroperitoneum, and he underwent his 3rd surgery. But soon thereafter, he developed a multifocal recurrence and moved to systemic therapy. He participated in a number of clinical trials, including everolimus and ribociclib, but he progressed after 4 cycles after dose reductions because of some side effects. He was continued on single-agent palbociclib, but progressed again after a couple of cycles. He went on to another study of selinexor versus placebo, but progressed after a couple of cycles. He 2 years later had surgery, his 4th surgery, to have resection of 2 large sites of disease on the right side and the left side. But again, about 6 months later, he had multifocal recurrence in the abdomen. So then he went on to his 4th line of therapy, which is a clinical trial of eribulin and pembrolizumab, but progressed soon after starting that, switched to doxorubicin, progressed after 4 cycles, treated with gemcitabine docetaxel, and remained on that for about 6 months, and then participated in a clinical study of the MDM2 inhibitor melanometin versus trabectedin, but he did not tolerate his assigned treatment and then decided to not pursue further systemic therapy. And he felt well when he was off treatment. he was off on vacation and had a history of heart disease and died of a cardiac arrest. This was a 14-year history from his initial diagnosis, but during that time, he did undergo 4 surgeries and 7 lines of relatively ineffective chemotherapy. So I think this is a not unusual history for patients with retroperitoneal dedifferentiated liposarcoma, but I think it also highlights our need to develop better therapies for this disease that can be both more effective and better tolerated. So I'm going to turn it back over to Nita now to talk about the rationale for targeting MDM2 and the review of the current evidence.
Perfect. So yeah, we're moving on to another targeted agent. We just talked about the CDK4 molecule. And I will review again what Dr. Wagner just said. So MDM2 is amplified in up to 90, I think it's a little over 90% of dedifferentiated liposarcomas. Actually, it's almost pathognomic to, if you don't get MDM2 amplification, it makes the pathologist wonder if they got the diagnosis right. It is an oncogene that inhibits the activity of p53 through the formation of this autoregulatory feedback loop. So the MDM2, there's the E3 ubiquitin ligase activity that triggers degradation of p53. MDM2 also blocks p53 from binding with targeted DNA, and it promotes the translocation of p53 from the cell nucleus by binding the N-terminal of the protein. So by inhibiting MDM2, you can kind of restore the function of p53 and keep it in the nucleus, and that's the premise of targeting this, especially in tumors where there is MDM2 amplification. So MDM2 antagonists have been in development for quite a while. And of course, liposarcoma is a characteristic for its MDM2 amplification, well known. So these agents have been tried in liposarcomas for a while, with the earlier agents being the Nutlin-1 category. And you have to develop better inhibitors, which are more focused with less toxicity. And that has led to a plethora of drugs that have been tested mostly in phase 1. So in this table, you could see a lot of the agents at the bottom are all in phase 1 testing. And a lot of these MDM2 inhibitors, what is interesting is, and we've put patients on, you do see patients who have responses on this agent after they have either not responded to any systemic therapies or with response to other systemic therapies, and then go on to this trial and have response. And also very prolonged PFS for some of these patients. They can be on this for multiple years. We'll talk about toxicity. They do have bone marrow toxicity. So a lot of these patients in these early trials, when the dosing was being decided, did have issues with requiring to come off drug because of thrombocytopenia. In some cases, neutropenia. What I'll focus on is the top 2 rows, which are the phase 3 study that's been done. And the MANTRA trial is actually the trial of meladimitan versus trabectedin, the phase 3 study that was done. And again, trabectedin has low activity, but it is still efficacious, in some cases. And so when you do a trial, depending on the number of patients on, so this phase 3 study, it was set for a PFS advantage, and it was not superior to trabectedin. So that was reported previously at ESMO 2023. And then the Brightline-1 is actually the phase 3 study of brigimadeline versus doxorubicin for frontline treatment of D. diff liposarcoma. Here, the outcome measured is like the phase 1b data, because we don't have the Brightline-1 data yet. It will be presented at the upcoming CTAS. We'll focus on this is the phase 1 results, not the Brightline-1 results, but this is the brigimadeline monotherapy, which is what created a lot of excitement and led to the development of the phase 3 trial of Brightline-1, where in the initial phase 1 cohort, patients with both well-diff, D-diff liposarcoma were treated. You could see in the swimmers plot, this is basically patients with well-diff or D-diff liposarcoma staying on. And the yellow are the ones that had MDM2 amplification. There were some patients where it wasn't confirmed to be amplified. And you can see a lot of those patients stayed on study for a while. They did expand the 1B with patients with D. diff liposarcoma. So there were 86 patients, and this was reported on in abstract form. You can see the objective response rate. So there was 1 CR, and the PR was 15 patients, 17.4%. Also, a lot of patients having stable disease with a disease control of 86%. the PFS was 8.1 month, and this is a preliminary out of the phase 1b cohort. So just, of course, encouraging for patients with high-grade D. diff liposarcoma, and seeing those responses was very encouraging with a targeted therapy with a different side effect profile than chemotherapy. This was presented at CTOS last year. This is looking at, they included 49 patients in this study where they were looking at the radiomic features and tumor response. They were analyzing tumor response based on that. In the dark blue were the 13 responders, and there were 36 classified as non-responders in the study, the lighter blue. And those are the ones where the tumors didn't, shrink, but for the responders is where the tumor actually shrank. So what you can see is patients, the responders had larger tumor volume and more homogeneous tumors. So the heterogeneity was a little less in the dark blue. The last column you see here, the heterogeneity was less in the responders compared to the non-responders. So that just tells you, like a higher grade, larger tumors are more likely to show shrinkage on therapy. This is just showing an example where you see from baseline to a 6-week follow-up scan. The top one is on a responder. I think there's no argument there that that's a response. And then below, there's a non-responder. And I'd say that there is a little argument there. It depends on the contrast enhancement. Of course, it seems like it became bigger, but there was some change that happened in the tumor for sure. And we have to wonder if the vascularity decreased and what else happened in that. But again, if there's a bigger, more homogeneously ugly looking tumor, it probably responds better than something that is heterogeneous. So anyway, and the treatment here was 45 milligrams of brigamadlin every 3 weeks. So this is moving on to another case, not very different from what Dr. Wagner presented, but basically presented a 47-year-old male presenting a little later than what his patient presented in 2015. The abdominal pain led to the detection of this large mass. Was seen by surgery first and then sent to us to see if we could do something to help reduce the size to get the patient to have a more optimal surgery. Given how extensive this picture doesn't capture how extensive the tumor was from going up to down. Patient received 2 cycles of doxorubicin ifosfamide, and the response was stable. We didn't see too much change in vascularity, nothing that suggests that I should have gone further with it. And at that point, we switched to gemdositaxel. This is the only one case that I've ever had. The patient received this treatment locally and ended up having hearing loss. So I've never encountered that before. This young guy is the breadwinner for the family, so we stopped chemo. He went to surgery, had an 18.5 centimeter D. diff liposarcoma resected, and the margins were free of D. diff liposarcoma, but were positive for well diff. He remained asymptomatic, unfortunately, only for a year, and then recurred in 2016. At that point, he didn't want to do anything. So he just, he was scarred by the therapies we had to offer at that time with chemo. So we just continued to monitor him. He ended up having multifocal recurrence in, the primary area of recurrence was initially where his initial tumor was, but then there were multiple areas even lower down in his pelvis where he had a recurrence. So he had his second surgery in 2017. Because he was refusing systemic therapy. He had a resection of these multiple foci. And then again, a year later, he presented with progressive disease. At that point, I had run the NGS panel that was available then and did not reveal any mutations, but showed multiple copy number variations. And those are the genes that were upregulated. He did go on because the selinexor study was available, similar to your patient. He was on the trial, but amazingly, so again, there's a lot of heterogeneity among these patients, right? So this patient ended up having, it says stable disease. The patient stayed on the trial for a long time, but when you actually looked at the tumors, there was definite change in the rate of growth of how he was before he got onto the study to when he was on the study. And then, of course, he eventually progressed on the selinexor, and we treated him on a clinical trial with immunotherapy. He progressed within 3 cycles, so we took him off. Then he went on to eribulin, and then he was on eribulin for a very long time. So that also, these unusual cases do exist with response to eribulin. And there too, there was some decrease in the vascularity and the tumors held, but then he started progressing quite rapidly with multiple areas of active disease within his multiple areas of tumor. At this point, last year in June, the arrow's missing, but June 12, 2023, he started brigamadlin, 45 milligrams every 3 weeks as part of the phase 1b expansion cohort. At this time, he's now 56 years old as of last year, and he's now, as of I just saw him a month ago, he's completed 23 cycles, and he's quoted SD by RECIST, and he did have a lot of nausea, which we controlled by pre-treatment with antiemetics before his oral therapy, and giving him he has antiemetics to take at home, and it continues for almost 3 to 5 days, and then it's better. But what I'd like to show here is the first image. The top and bottom is the PET CT scan right before he went on to the study. As you can see, a lot of PET avid disease there. And then 4 months in, which was the last PET CT I got, I stopped doing PET CTs after that, you could see a significant decrease in all the PET avid disease. And if you look at the middle column, the top is again a pre-treatment, and the bottom one is just the most recent scan that he had done. As you can see, you have these masses there, and within the masses, the vascular areas, I know the pointer is not, I'm pointing in with the arrow, but those ones really did decrease. And so there is definitely even a size decrease, and the vascularity within the big tumor has decreased. As well, in the last column, you can see this mass in his right pelvic area, and this muscle implant has quietened down completely. There's another cut where you can see just calcification now in his tumor. So I would call this a response, but the study is going to call it a stable disease. And he's continuing to do well. So in the Brightline 1 study design, which was prompted based on these results from the phase 1 study, this is a phase 2/3 design where the plan was to randomize. The first phase 2 was a 3-part randomization because they needed to collect data on the 30 milligrams Q3-week dose as well to see how it compares to the 45 milligrams Q3-week dosing and versus the standard single agent doxorubicin 75 milligrams per meter square every 3 weeks. There was then an interim analysis for dose selection between the 2 brigamadlin arms, and then selected the optimal dose, which was selected at 45 milligrams every 3 weeks. Then was additional patients, so they had to wait for the interim futility analysis up to 56 PFS events, after which they embarked on the phase 3 portion of the study, where they enrolled 120 or greater patients were supposed to be enrolled 1:1 to the brigamadlin 45 milligrams Q3-week dose versus the doxorubicin dose, and then patients were in follow-up. And the treatment is to continue till disease progression, unacceptable AEs, or consent withdrawal. So again, this study has completed enrollment, right? And this is the data that will be presented later next month, where we'd analyze what the outcome was compared to doxorubicin. So moving on to a case. This is a fictitious kind of name, I guess. This case is similar to some that we've treated on the phase 3 study. 70-year-old woman with adenoid liposarcoma in the retroperitoneum and has received 3 surgical resections. So I'm assuming 3 surgical resections. Andy, Dr. Wagner, I'm gonna pose it to you. So what are you thinking about when you're seeing this patient as a new patient comes to you with another recurrence?
No, thanks. So, I mean, the first question is, how long ago has it been since our last surgery? And if it was recent, then it kind of plays our hand to thinking about systemic therapies. But I also want to know what surgery was performed, and was it inadequate surgery? Because sometimes we'll see partial resections of disease when more surgery could be performed. The other features related to that too, aside from the careful assessment from a surgeon, is she physically fit for more surgery? What are her symptoms related to her disease, and things like that. But let's assume that surgery is not an option, or that she has had surgery, let's say in the last year, in which case the rapid recurrence of disease would suggest that more surgery is probably not the best idea right now, because she'd be likely to recur again quickly after recovering from that surgery. So systemic options, I would, from a standard perspective, again, depending on amount of disease, her overall health, and her other comorbidities, I would still reach for an anthracycline first. As we discussed before, it could be single agent or in combination with ifosfamide, taking account her age and her prior surgeries, that might be more difficult to administer to her. And we'd also look to see what clinical trials do we have available right now. And of those trials, are they restrictive to patients who previously had systemic therapy, or could it be used in the first line? There have been some great studies that have come through recently that have also accrued very quickly. For example, a study of a CDK4 inhibitor with immunotherapy just completed enrollment. So the studies will come and go. Again, they'll have different eligibility criteria that might require prior chemotherapy. So those are the types of things I'll be thinking about. But typically it would be with an anthracycline, and sometimes it would be liposomal doxorubicin just to try to control her disease, especially if she's elderly or frail or has other comorbidities. What would you do?
Yeah, I agree completely in the sense that you have to take into account what the current recurrence looks like, how long from the prior recurrence, what is your surgical colleagues telling you, what is her performance status, and what are her wishes? Because sometimes you have these options, and then you have to, take into the patient's what their schedule looks like into consideration and decide what you do. And D. diff liposarcoma can be various. So if this is a very fast growing recurrence, I would, standard of care, I would go to something like chemotherapy. Just as you mentioned, doxorubicin single agent for a 70-year-old probably would start single agent and then see. Sometimes they can tolerate, if they can't tolerate doxorubicin, gemcitabine-based therapy is tolerable. You do have to adjust the standard day 1, day 8 also can be quite toxic, so they might need some adjustment. And again, some rare cases will benefit, and those patients who benefit can benefit quite a lot. I think if the recurrence is a slow-growing recurrence, those are the cases where you would think about targeted therapies, and I know there is NCCN guideline recommendations have CDK4 inhibitors in that. And, again, you saw the response rates not very high, but some patients can have stability and it will buy time between surgeries if they're not right way, to go in to see if it can change the course of the disease. And then clinical trials always. So if you have a frontline trial available, it obviously makes sense because it's probably targeted to the disease. It allows you to treat patients without prior exposure to chemotherapy. And in these patients, you can see their spectrum is there. They have a natural history that can go many years. So you've got to try to expose them to all the options. So if there's a trial, obviously I would select that and leave the other options for later.
Yeah, and I think it's a good idea also if you're in a community setting or at a site that doesn't have a lot of clinical studies, is just to check in with one of your colleagues at one of the academic centers that do have a lot of, or one of the centers that has a lot of studies, to see what's in the works and what's coming, because that might also help you choose a study option. So, for example, if there's a study of, let's say, a CDK4 inhibitor in combination with another drug, but it requires first-line therapy, then you may not choose a CDK4 inhibitor up front because that would impact the ability to put a patient on a study in the future. So I think it's always wise just to check in and get the view of the landscape of what studies are available so that you can plan your choice of therapies up front accordingly. The other group that we should also talk about, including in these discussions for localized and particular symptomatic recurrences, is radiation oncology. Radiation can be an effective mechanism for controlling disease, especially if it's symptomatic. So that could also be an option.
Absolutely.
And what about molecular testing? We briefly talked about this before. Do you routinely do it before starting systemic therapy?
Wouldn't unless there was a clinical trial that required it, right? So we wouldn't, I don't think it changes if you know the diagnosis and it's confirmed, it might not change what you're going to do. But I think we're using it more because the platforms of NGS are becoming broader. So there might be some data that might be helpful. Like we do get the immune profile as well with it. And that might, because, we talked about immunotherapy response. What are those few patients who are responding? If we can get more information, we might be able to prioritize trials based on that if we have more than one trial available. But I can't stress the point you just said, it's really, we're trying to get them as many options as possible that will enhance their outcomes. So checking in with centers which have trials or looking for trials for this before you start a therapy is key. But molecular testing might not change your frontline treatment right now, but it has implications. So I think it is something that we will see more about. But it's, because there are different ways of doing MDM2 amplification. For a clinician, right, if you want to see how amplified, then it's usually we end up having to do the NGS panel to get that done.
Right. All right, maybe we should move on to.
We should move on. I think we already covered
Yep.
this. We'll
Yeah.
move on to the next because it was just continued. So before we move on, please take a moment to answer the 2 follow-up polls on treatment selection and recent clinical evidence for advanced DDLPS. Okay. Andy, you want to lead this, the role of multidisciplinary team in addressing adverse events with MDM2 inhibitors? Again, I'll pose questions to you, I guess we can do it that way. But the main thing to remember with all the MDM2 inhibitors, including brigamadilin, is their side effects fall into GI toxicities, which is like nausea, vomiting, usually around dosing. And then it starts getting better towards the end of those 3 weeks. And then the main one is thrombocytopenia and then neutropenia. So those can be prolonged. So it's important to know when you see neutropenia and thrombocytopenia, at what level would you do? Here we'll just, of course, it's not standard therapy. You follow the protocol, but you have to hold the dose and then you have to retreat when the counts recover. And those neutropenia and thrombocytopenia were the most common grade 3 or higher treatment-related adverse events. And they usually don't present with bleeding, and they usually recover when you stop the drug. So that's important. And the number of patients who had to had to discontinue treatment completely was still low, was 7% because of these AEs. So, Dr. Wagner, I will pose this question to you. What adverse events should we prepared to manage when we're considering MDM2 inhibitors in our treatment?
Yeah, I think, as you mentioned, as a class effect for MDM2 inhibitors, we do see nausea, which can be pretty intense, and myelosuppression, in particular thrombocytopenia and neutropenia. The nausea often requires multi-agent antiemetics as prophylaxis, and that can usually help quite a bit. And there are different regimens that have been constructed, but often including dexamethasone, sometimes olanzapine, sometimes ondansetron, other agents like that. The myelosuppression needs to be carefully monitored. One thing that we saw with some of the other MDM2 inhibitors is delayed thrombocytopenia, and that can be persistent and prolonged. So it does require careful monitoring of the blood counts. Counseling patients, reporting nausea early is certainly important because we want to escalate the antiemetics up front. Again, I think that's probably the most important thing with this class of drugs is to make sure that patients are telling us what they're feeling, or we're checking in with them to find out how they're doing. But the neutropenia, you could use growth factors. I think holding drug, reducing doses described in the protocols for these is important. Thrombocytopenia, some people do use end plate to help support the platelet counts if needed. I don't think we commonly see a need for transfusions with this, but sometimes it does require holding treatments for a bit of time until it recovers. Those are the most important, I think, situations for dose interruptions and dose reductions. Again, because these are investigational drugs, we're often directed by the study protocol for how to reduce drug. But if someone's having recurrent grade 3 events, I think it makes sense to reduce the dose of drug.
Right.
Yeah. And then grade 2, even grade 2 neutropenia after a 3rd cycle of treatment, this might also require holding the dose and considering reduction, depending on what the protocol says in that setting.
Yeah, you covered it really well. And you're right about the nausea, because that's one that prevents patients from taking it. So you have to be aggressive. And then if you treat, it's better. So that was a good overview of that. So before we move on, again, please take a moment to answer 2 follow-up polls on adverse event management and your understanding of targeted therapies for DDLPS.
Yeah, so just to summarize, both well-diff and D-diff liposarcoma have the same amplicon that activates P53 and RB, but can have very different clinical behaviors. We don't yet know what else is different that makes it into dedifferential liposarcoma. This is an area a lot of groups are currently studying. Recurrent disease is very common. It often requires multiple surgeries. Conventional chemotherapy can help, but it's usually somewhat short-lived in terms of efficacy. We need to develop better therapies, especially targeted therapies based on the biology of these diseases. We've seen some good preliminary efficacy and safety of MDM2 inhibitors. Ongoing studies are important, and figuring out how to use these drugs is also important. But with any drug like this, being vigilant about monitoring and managing side effects is really important. Maybe we can jump to some questions that we've received from the viewers. So maybe I can start with, we've covered some of these. So there's been some questions about molecular analyses. I think we talked about that, about FISH, about potential role for next generation sequencing. There's some questions about combining agents. It's a question of a combination of MDM2 with immuno-oncology trial. What do you think about that?
It's interesting. So there was a study with APG-115, which is an MDM2 inhibitor and immunotherapy combination. And I think we did treat some D. diff liposarcoma. So it's interesting. I think that the thought is there is, with immunotherapy, there's sometimes you can see MDM2 get amplified as a resistance mechanism. So that was the early thought of combining it, not only for liposarcoma, but for other disease types. So I think there is something there, but we still need to see benefit from trials or seeing the trial design correctly to see the outcome. But there is some preclinical rationale there.
It's a great opportunity for a study. I mean, I think it's a really, and it's possible that by triggering apoptosis or releasing more antigens might trigger some immuno response. Yeah. What about, is there a role for adjuvant treatment after resection of retroperitoneal dedifferentiated liposarcoma?
So now I'll answer another question. I saw that would you ever do a surgery without a biopsy if the clinical or the radiographic picture is accurate? And yes, these patients will present to the surgeon, and sometimes they might do it when the patient is going to be surgically resectable. Majority of times they would want a biopsy unless this was a clear cut. But if once the patient is resected, I would say for D. diff, or definitely not well diff, but D. diff liposarcoma, I don't offer adjuvant chemotherapy because the response rates, as you saw with chemotherapy, are lower. And yes, these patients were included in the adjuvant study trials and then the meta-analysis, but we don't know if it alters the biology. As you saw, these patients could recur after 10 years. And if that's a patient you're treating up front, I don't know, are we doing anything good to prevent their recurrence in 10 years? So it makes more sense, and which is why I said when the recurrences get more frequent, you start seeing the pattern has changed. Their disease biology is changing. Those are the ones you'd want to then come in with the chemo before they undergo another surgery within 6 months, to try and see if you can change that. At least that's what my practice.
Yeah, no, I agree. I think as you just pointed out, the disease-free interval can be quite long after surgery. So it is difficult both to assess and the effect of chemo as well as the need for it. So I think observation makes more sense in that setting. As we mentioned, a neoadjuvant approach. Right now there's a study, STRASS-2, neoadjuvant doxorubicin and ifosfamide for retroperitoneal liposarcoma prior to surgery. So that is an option. Someone posed a question about any paraneoplastic syndromes associated with this. I can't say that I've ever seen. Have you?
I haven't. I do recall there was a patient, but it wasn't a D. diff liposarcoma. I was just trying to think as I saw the question. But it is not a common presentation at all.
Yeah. There's another question about the potential role of pazopanib, maybe other VEGF receptor antagonists. Have you much experience with using it? Even it's not, as we talked about, it's not part of the label of pazopanib, but
so yeah,
might use it off. Anyway.
Able a little bit. So, when you run out of options, you use it. Also, the history is interesting, right? The phase 2 study, actually, they didn't see a response in the adipocytic tumors. So they removed it from the phase 3 study, but then they had to reclassify patients on the phase 2. And then they realized technically liposarcomas would have met the cutoff to actually be included in the phase 3. So we did run a phase 2 study for liposarcomas with pazopanib, and there very few responses, but some patients had stable disease. So there are these random responses. So I think it's still some that, insurance does cover it for sarcoma, so you can sometimes get it, but it's definitely not one you use upfront. Plus, these patients usually go to surgery, so you want to avoid VEGF targeted agents.
I agree. There's another question there about the frequency of imaging after resection. What's your approach?
Yeah, that's a good one because it's so variable, right? I think I always start with every 3 months in terms of when it's surgical resection is complete and we don't have any residual disease. do say, we have to change I think for well-diff, purely well-diff liposarcomas, or even tumors that we're following with well-diff that are not changing very frequently. We looked at our data and we saw that there was really no difference if you did 6 months versus 3 months. So for someone that is low grade, you don't need to have such a, high frequency of imaging. But for the D. diff liposarcomas, initially, it would be that frequent. And then patients who have been disease-free for a while, post 2 years, post 3 years, you could increase that interval of imaging, based on the
Yep.
patient
No,
history.
I completely agree. And I do, as we talked about in some other cases, I do think extending follow-up to, we usually do to at least 10 years is important just because of the risk of late recurrences. Thank you all. Please visit PeerView, SARC 2024. You can complete your post-test and evaluation for credit and download the slides and practice aids. You can watch the replay. Thanks for joining us.